Greetings, everyone. My name is Tometta Cozart. I serve as the Multicultural Outreach and Health Equity Director for the Epilepsy Foundation of America. I want to welcome all of you to our Epilepsy and CMV Connection Awareness webinar. Today, we are having this particular webinar so that we can learn more about the fact that 1 in 200 infants are actually born with congenital CMV. And in that, there's 1 in 5 children who will have permanent disability or health conditions. And some of those conditions do include the aspect of having seizure disorders and epilepsy. So today we wanted to make sure that we provided an opportunity to learn more about that connection, and that we also increase awareness of the aspect of epilepsy amongst the CMV population. And so this is a subset of our epilepsy community, and we want to make sure that we are working together to be able to support them. So we have invited you all to learn more about this connection, and we hope that you find this opportunity to be able to have more resources and to be able to connect more people to our existing resources and providers. I want to say thank you so much to Dr. Kalia Fleming, who is the Executive Director of the National CMV Foundation. The Epilepsy Foundation, and specifically the Multicultural Outreach Program and Health Equity Program, are a part of the partnership collaboration team that is with the National CMV Foundation. We are one of several organizations, including the American Academy of Pediatrics, that actually works to be able to serve the CMV population in addition to the epilepsy and seizure population. So Dr. Clea Fleming is going to give us more information about the foundation. Her particular role as the executive director means that she has the strategic guidance of the organization in addition to their advocacy, outreach, and education efforts. She is a certified health educator herself. She is professionally trained in public health. She has her doctorate focused on health equity and in health literacy. And she also is a past Peace Corps volunteer, having done education and community outreach in Peru. So without further ado, I'm going to actually turn it over to Dr. Fleming.
Thank you, Tometta, for that warm and wonderful welcome. Good afternoon, everyone. Thank you so much for joining us for today's webinar. I'm sure it will be very resourceful and extremely informative to those who are attending live and those who will also catch the replay. Next slide, please. All right, so June is CMV Awareness Month. So again, thank you to the Epilepsy Foundation for partnering with us to host this webinar. We hope it really increases awareness about congenital CMV, as well as action items and next steps that folks can do to increase awareness and advocacy about CMV overall, but especially as it relates to the connection with epilepsy. Next slide, please. So a little bit about congenital CMV. Congenital CMV is the most infectious cause, or CMV, cytomegalovirus, is the most infectious cause of birth defects and is the leading non-genetic cause of hearing loss in U.S. infants. We're talking about roughly 3 out of 4 adults, so 75 to 80% of us would have had CMV at some point in our lifetime and would not have known it. I'll get a little bit into more stats, but it's a very, very common virus and typically is harmless, does not cause too many issues or problems unless we're talking about pregnant women who unknowingly pass the virus to their unborn child or those who are immunocompromised. Every pregnant woman is at risk of acquiring CMV. Again, most people who contact CMV will have no symptoms, won't even know that they've come into contact with this virus or have it. It's often called a silent virus. We often hear mothers who say, well, I thought I had a cold or maybe a sinus infection, right? So if individuals do have any symptoms, that is what it could mimic. But again, most folks will not know that they have this at all. If a woman gets CMV while she is pregnant, it can cause disabilities in the baby, which is called congenital CMV. And that's why we're here today to share more information with you about it. Next slide, please. So a little bit about data, stats, numbers here. I want to really pay attention to what is the far right for me, 1 in 200. And we have an image that is really going to help hone in on that data stat, that data point. So roughly 1 in 200 children are born with congenital CMV each year. And to some folks, we may think, okay, that's how common really is that? And we'll explain that a little bit more. Next slide, please. So this is how common it is, right? And this also speaks to awareness. So if you look here at this image, this graph really is to highlight how much folks know about these actual conditions, right? So you have these blue bars and then you have the orange dots. So the orange dots are the number of children that are disabled by the condition that's represented by the blue bars, which is awareness. All right, so if you look at this graph, you'll see something interesting. You may think back to that last number I said, 1 in 200 children. Well, if you look at the orange dots here, you'll see congenital CMV and Down syndrome are pretty much running neck and neck here with these orange dots. So a lot of us have heard of Down syndrome. Most of us have heard of Down syndrome. And it seems like it's just as common as congenital CMV by the orange dots. However, not too many people, you'll see the blue bar is very small, very slim compared to Down syndrome, which again represents awareness. So here we have an issue. You have something that's running neck to neck with the number of cases per year with Down syndrome, but you have Down syndrome, which has way more awareness, way more people are aware about it versus congenital CMV. And that's really what this actual graph is representing. Next slide, please. So we learned a little bit about CMV. We learned some data, some stats. You may be thinking, okay, well, how is it transmitted? Transmitted through bodily fluids, so saliva, tears, urine. It can be genital fluids. We talked about immunocompromised. So sometimes you think about those who go through organ transplants, blood products, transplant center, right? But our focus is, again, those of childbearing age. In particular, women with young children who work at or their children go to daycare or childcare centers may be at a greater risk for contracting CMV during pregnancy. Why? Because children go to daycare and they're constantly shedding viruses, passing germs. It's a hot spot for all these things, right? So studies in childcare settings suggest that as many as 75% of toddler-age children have CMV in their urine or saliva. So what we often see is these children who then come home to their families and interact with their mothers who are pregnant. And then that is how that transmission could happen as well. And that's also a focal point for educational resources and services that we offer to childcare centers and daycare providers. Next slide, please. So some possible outcomes, as Tameta mentioned, and as I mentioned, it is extremely common, but not everyone who gets CMV will get sick, as I mentioned, and not every pregnant mother who catches this virus will have a child with severe disabilities or health complications. What you're looking at numerically is about 1 in 5 of all of those children impacted with CMV will have major health complications. So roughly 20%. And it really runs the spectrum. It really runs the gamut with how disabled or the challenges, how severe the challenges that they will face, right? So we do know that CMV, and while we're here today, has been linked. There is a correlation with epilepsy, seizures, feeding tube issues. We often see failure to thrive in some cases, vestibular issues. Again, it's the #1 cause of non-genetic hearing loss. There are vision impairment issues that can happen with those children who do suffer from complications from having the virus. It has been linked in some cases to stillbirth and miscarriage as well. And then you have children who are seemingly fine. We do see in some cases late onset hearing loss and late onset or development of different complications due to a CMV diagnosis. So it's very important to monitor these children once they get a CMV diagnosis and make sure they're properly diagnosed fairly early on so that we can properly monitor and track their progress along the way. So again, it really runs the gamut with how severely impacted those who will be impacted are or will be. Again, there's a huge spectrum here. It's our job, again, to really highlight that 1 in 5 of those children will have serious health complications that do need to be tended to and monitored. And that's why we're here raising awareness. And again, there is a correlation to epilepsy, seizure, cerebral palsy, and a slew of other items that you see here on the screen as possible outcomes. Next slide, please. So a little bit about our organization. So this is a milestone, pivotal year for us overall at the National CMV Foundation. This is our 10th year, so it's our 10-year anniversary. Milestone for us for sure. We've been incorporated for 10 years and really have been doing this work at a steady pace, consistently, with dedication and passion since 2014. Our mission is to prevent pregnancy loss, childhood death, and disability caused by congenital CMV. And we do that through a slew of programming, offerings, advocacy efforts that really try to get at the heart of the mission. Next slide, please. And we are a conglomerate, a group of parents, scientists, advocates, CMV researchers, caregivers, and we all really kind of fit under, the organization serves our community under these strategic goals, if you will. So raising awareness through advocacy. We have provided plenty of support to different state-based advocacy groups that are working to pass various CMV legislation in their respective states. Right now, there are 21 states with some form of CMV legislation enacted. So really excited to support their work. This year in March, I believe, yes, in March, we actually had the Stop CMV Act introduced in Congress, and that has been a labor of love that we've been working on for more than a year with different CMV partners and advocates. We also accelerate mission-driven research. We support high-impact CMV research that really kind of fuels our mission and helps us get more data in alignment with our mission. We target education programs, create targeted education programs. So again, we really want to provide educational tools, resources, and training to those childcare providers I mentioned earlier, daycare centers, daycare workers, a variety of healthcare professionals, allied healthcare professionals, but also pediatricians and OBGYNs and others in the healthcare arena, as well as families of childbearing age and the general public. Grow resources in support of the mission. This is huge for us. And, June is CMV Awareness Month. So we're out here hosting a slew of fundraising events and awareness events to ensure that we can continue the great work that we're doing. And then we have to demonstrate a commitment to diversity, equity, and inclusion. We do know that there are disparities when we talk about congenital CMV, especially when we consider socioeconomic status and disparities in the BIPOC community. And so these are our strategic goals that really guide the organization. Next slide, please. And so I just want to say here before I introduce Jasmine, that's her and her son Jackson on this lovely photo, is where you can go to learn more information about the organization and to stay abreast of our ongoing activities. We have several. If you follow us on social media, you can find us on Facebook, LinkedIn, Twitter, Instagram. We have a slew of different campaigns and activities going on all year, but especially this month for CMV Awareness Month. You can find us on those social media channels. You can also find us on our website, nationalcmv.org. A lot of great educational downloads and materials available for the general public to use. And should you have any questions after today's presentation related to the work of the foundation or CMV in general, feel free to send us an email at info@nationalcmv.org, and we'll make sure it goes to the appropriate team member. Now, without further ado, I'm super privileged and honored to really introduce the stars of the show for today's webinar. The first being Jasmine Webster. You see her here on the screen. Jasmine is from Birmingham, Alabama. She is a devoted full-time stay-at-home mom to 2 boys, ages 8 and 15. Her life was personally touched with CMV when in 2015, her son Jackson was born with CMV. What that ended up doing was actually fueling her passion to learn all that she could about CMV and to become a CMV advocate, as well as an advocate for epilepsy and cerebral palsy awareness. We will shift quickly to Jasmine sharing her and Jackson's CMV and epilepsy journey and story. However, after Jasmine, I wanted to quickly introduce the next speaker, and that will be Dr. McNamara. She's a pediatric neurologist at the University of Michigan. She takes care of children with epilepsy, mainly those with treatment-resistant epilepsy, which actually goes a long way back for her. That actually piqued her interest in pediatric epilepsy, which started as a child when her younger brother was treated for resistant epilepsy. She currently serves as the co-director of the Comprehensive Pediatric Epilepsy Program, housed at the University of Michigan. So without further ado, I thank you all for listening in. I'm going to turn it over to Jasmine to share her and Jackson's story. And then after Jasmine, we will hear from Dr. McNamara.
Hello, everybody. I'm Jasmine Webster. I'm a parent of an 8-year-old son who has congenital CMV with the epilepsy diagnosis. My CMV journey started when I was 4 months pregnant. I was at the time working at a child care daycare when I was pregnant. I had Jackson at 34 weeks in a day. Watched very closely with the silver specialist during my pregnancy. Jackson stayed in the NICU for 2 weeks so he could do his valsite dosage, which is what they use to help treat, the CMV symptoms. And also we did other tests as of MRIs, blood work, trying to make sure his specialists were coming in where he can return home and, have a successful journey as he is now. So he came home right before Thanksgiving, which was exciting for everybody in the family. Jackson really just he was the smallest thing, but had the biggest personality, even right now. So Jackson, right after Thanksgiving, we quickly started meeting our hospital family. We followed up quickly with our neurologist. Our neurologist put us on our first medication, with a lot of parents might be familiar with, is phenobarbital. That was what Jackson started out with, and we are still on it as of today. Um, I, I'm glad that for my team of doctors, for my education, for my strength. Even in the NICU, with the infectious disease doctors, they really helped me connect multi-diagnosis. So they really helped me lead the way to how CMV can quickly affect hearing. They made sure that Jackson followed up with every specialist as he should. Also, Jackson he has a G tube. He is still G tube dependent. We follow very closely with rehab medicine and neurosurgery because Jackson, he has muscle issues. We see therapists, so he has a baclofen pump. He got his baclofen pump in 2019. As of March of 2023, one of his stories were he had to get an emergency replacement because that one malfunctioned. But as of now, a year later, it's working, no malfunctions. Jackson is thriving. Jackson is doing good. I always want to address all the family members. You all stay strong. Stay strong. I know it sounds cliche, but it's really what you can do. Is all we can do, and it's what get these babies, these kids. However, we look at them through the day. When we strong, they strong. They feed off us. So we got to take care of us. We got to take care of them and advocate. I'm thankful for this opportunity. I want to keep advocating, whether it's in Alabama, worldwide. I want to make sure I speak up for everyone with congenital CMV and educate for everyone, the kids and everybody. I also want everybody to know, just stay on top of everything, stay aware. Never hesitate to ask a doctor anything, whether you're a family member or whether you're the actual pregnant person. Just make sure you advocate for yourself and you advocate for your family members too. CMV is a big thing. That's why we're trying to put it out here now. So thank you everybody who's listening, and I'm looking forward to speaking with everybody again. Thank you, Dr. Fleming.
Thank you. Wonderful job. Next slide, please, as we transition to Dr. McNamara.
Thank you for the kind introduction, and thank you, Jasmine and Jackson, for being here. I am primarily a epilepsy expert. By no means do I have specific expertise in congenital CMV, but it goes hand in hand. And you met Jackson and heard that he has epilepsy. And it does affect some children with congenital CMV. And I suspect that the other people who are on this webinar are probably people who have been affected by perhaps seizures or epilepsy as well as congenital CMV. So I'm honored to talk to you a little bit. This may not be as in-depth as some people want it to be. It's 20 minutes, but I wanted to give you an overview about the significance of seizures when people have congenital CMV and sort of some of the framework in which to think, especially if this is kind of a new diagnosis. So I put this together thinking about how I would talk to a parent or a family who has been newly diagnosed with epilepsy or seizures in the setting of congenital CMV. And again, I'm a clinician, so I primarily take care of children with seizures and epilepsy at University of Michigan. You can go ahead, see the slide. I have no disclosures. And so I was asked to talk about the connection between seizures, epilepsy, and CMV. Then I was also asked to talk a little bit about the impact of seizures in children, you can just say children in general, and why we want them to stop. And then some tips for parents and pediatricians. And Jasmine was actually able to give some of these tips for parents and pediatricians. So I'm not going to repeat what Dr. Fleming said, but I think it's just important to know. I actually remember learning about congenital CMV when I was in medical school. I hadn't heard about it when I was in my young 20s. It's just this virus that floats around everywhere, and most of the time it causes no problems, but it can cause lots of problems. And it can really cause a problem if somebody's pregnant and they get ill with it. And the tricky thing and why people don't know about it is it's oftentimes missed. And oftentimes the babies, when they're born, they don't even have signs of infection. It's kind of rare that they do. And sometimes you figure it out in retrospect because the children will have hearing loss and fail their first hearing test. And then people think to look for congenital CMV. There's not like a specific rash that goes along with it. Or sometimes children will have their first brain MRI because they have a developmental problem, and we'll see kind of the markers of congenital CMV. When children do have signs of infection at birth, they will oftentimes then develop developmental issues. But again, some of the children don't have any signs of infection and will have neurodevelopmental issues, and we just figure it out later because of the problems that may develop. You can proceed with the slides. And what's tricky is anybody can have a seizure. Any brain can have a seizure. And that's always like a tricky concept to hear. Chances are you guys have all known somebody or heard of somebody who has had seizures, but really any brain can have a seizure. In children born with congenital CMV, they can actually have seizures at the time of birth just from having an active infection. So any infection at the time of birth in a neonate can cause seizures, but especially one that goes to the brain, and especially congenital CMV. How I often think of seizures being caused by congenital CMV is when it causes a long-term problem with the brain. And the things that come to mind as a neurologist that I'll kind of show you pictures are of when children have CMV infections very early in utero in development. The brain development is a magical, wonderful thing. And if an infection occurs early on, it can actually cause disordered development of the brain. So very early on. And some of the words that we use and some of the pictures I'll show you, the two classic things in congenital CMV are can cause things called schizencephaly, which is a fancy word, kind of tricky, but I'll show you a picture of it. And then also polymicrogyria. So these are just two names for brain malformations. You can proceed, thanks. So timing matters. So when the brain, again, every time I have to review with the residents neuronal migration and brain development, I'm just like amazed that it happens all the time so well. Early on, if there's an insult to the brain or the fetus is exposed to a virus, for example, or a toxin, you can have injury. And the earlier a child has a CMV infection in utero, the higher the severity of disease. This is kind of the classic teaching. So the earlier on, the more injury you'll see, or the more malformations that you'll see. And later on, when a child has congenital CMV infection, again, the classic teaching is that the disease is not as severe. This obviously is not an always kind of statement. The brain malformations that occur, we think that some of the malformations that I'll talk about, like the schizencephaly and the polymicrogyria, those occur less frequently than calcifications. And calcifications are sort of the thing that we're taught to look for. However, I don't think we actually know, right? We're not going around and testing pregnant women or fetuses early on. And so sometimes we actually just see the malformations that occur later, and we suspect or wonder, was there an early infection? And so that's why I always think that this stuff is tricky, because when you actually review the literature, which I'm sure that some people have who are on this webinar, it's tricky when you don't actually have the data from who actually had infections early on. So gray matter, or kind of the surrounding of the brain, kind of the wrinkly part of the brain, that's where cell neurons live, and that's where seizures tend to come from. And in congenital CMV, like I talked about, you can have neuronal migration disorders, you can have problems or changes in the formation of some places notorious to cause seizures called the hippocampus. You can actually just have atrophy or like injury of the brain, and that can lead to seizures. And oftentimes when you have injury of the brain and what we call atrophy, the infant will have a small head. And so it's another kind of classic thing that we talk about in congenital CMV. You can proceed. Thank you. So I'm a picture person. I have a hard time with just words. So I wanted to kind of show you this. So this is a picture of a normal MRI that I found. And maybe some of you have never seen an MRI. So this is like a cross section of the head right about here. I don't know if you can see my arrow, but the top is the front of the brain. The back is the back part, or the bottom is the back part of the brain. And actually right is left and left is right, but that's not that important for what we're talking about. What I wanted to show you is the gray matter. So gray matter is kind of the ribbon all the way around the brain. And that's where the neurons bodies live, and that's where seizures come from. The white matter, which on this picture is the darker color, is actually the connections between all of the neurons. And again, the whole thing is just amazing that we all form so well. And so when children have problems with their gray matter, that's typically when you see seizures. You can proceed. And so here, so what we're classically taught is the picture on the left. So this is a slightly different version of an MRI, but there's an arrow, a yellow arrow pointing to what we typically think of when we think about congenital CMV, which is that you can get calcifications in the brain. And they're usually, calcifications are typically in white matter. And here are on the B side shows some other white matter abnormalities, including cysts in the brain. In reality, like all brain injuries and malformations have the tendency to cause seizures. These ones I would think of less likely to cause seizures, but they can definitely cause neurodevelopmental problems, cerebral palsy, so problems with movements, sometimes problems with thinking and cognition as well. Next slide. It's when the gray matter is disrupted, that's when you tend to have more seizures and when you tend to meet a pediatric epileptologist like myself. And so again, here's this normal picture of the brain on the left side of the screen, showing like this, it's actually a very beautiful ribbon of gray matter around the brain. And then on the right, I just found a generic picture. I couldn't find one specifically of somebody with polymicrogyria and from congenital CMV. But can you see how in that red arrow, kind of have to picture that there's actually more folds than you even see. There's actually a whole bunch of abnormal neurons or gray matter in there. And that's just in our world of epilepsy and seizures, that's just a setup for causing abnormal connections and abnormal electricity and thus seizures. And you can go to the next slide. And here is a picture. So the top picture was polymicrogyria, which is too many folds. The middle picture actually has polymicrogyria in it, but see how that you can see that like white cleft in the middle? There's a circle with a red circle, but right in the middle, you can see kind of that cleft. that's actually called schizencephaly, and that entire thing has abnormal gray matter in it. And gray matter is where seizures come from. And if you have abnormalities in your gray matter, that's a setup for seizures. And so that's actually on the left side of the child's head, of the child's brain. And I would suspect that that would cause seizures or problems on the right side of their body. Very importantly, and this is what I say all the time, I can't actually look at an MRI and predict exactly what that child looks like or if they have seizures or not. I can just tell you, not because I'm trying to avoid the question, but I can just tell you what I think I might see. But I say this all the time in clinic, which is I would not have expected this based on this MRI, or, oh, yep, this makes sense. Or, you know, just like on the bottom picture, yeah, this is on the left side of your head. It's pretty close to motor cortex. And so maybe this child has problems with the right side of their body. Maybe they have seizures, maybe they don't. I can be totally wrong because the brain is very different and from each person, and their anatomy and their function is different. And so a brain MRI only shows anatomy. It doesn't actually show you function for the most part. And next slide. So long story short, I've said this a couple of times, but in children with congenital CMV, those with brain abnormalities, especially when the brain abnormalities involve the gray matter, those are the children at highest risk for seizures. Next slide. And so what are seizures? So seizures are abnormal electricity in the brain. Anyone can have a seizure. You may know somebody who has a brain tumor and has seizures from that. Where that seizure is occurring in their brain can lead to different symptoms. And so maybe you've seen in a movie where somebody has a big convulsive seizure with tonic-clonic jerking. Well, those tend to be kind of obvious seizures that tends to involve both sides of the brain. But seizures can be more subtle than that, and I'm not telling you any of this to scare you, but it's just that seizures, they manifest by where in the brain they're occurring. So if a child is having a seizure, you know, right over motor cortex on one side, like that picture I just showed you, maybe you just see jerking, rhythmic jerking of the opposite side of the arm or leg. Or maybe the seizure is occurring deep in what we call the hippocampus, which is a common place where people have seizures. And they might just all of a sudden get a feeling of deja vu. You can't see anything out in the outside, but inside their brain, there can be abnormal electricity causing symptoms. But people, especially what I'm talking about here, unless there's like a big brain injury or something that happens, people don't tend to just have one seizure. They tend to have kind of recurrent seizures. Let me say this again. So if somebody has epilepsy or the tendency of seizures, you don't usually just have one and then like never again on medicine. You tend to have one and then they become this recurrent thing, which then is what is brought to our attention as the pediatric neurologist or the pediatrician. Some seizures can just be very focal and just cause abnormal jerking or a weird sensation. You can have seizures where you can have retained consciousness or awareness, like, oh, wow, look at my hand is jerking. Mom, my hand's jerking. Or sometimes the children lose consciousness. And so it just depends on where in the brain the seizures are occurring. Again, as a picture person, I wanted to show you some pictures. And so if you can push the next arrow. The EEG on the top is one of my patients who has seizures coming from his temporal lobe. And I don't need to teach you how to read an EEG, but during the actual seizure, this is what his seizure looks like. I tried to draw an arrow to those black lines that are kind of going in and out and in and out. And that is when he actually has deja vu. That's right when that's occurring. He otherwise looks okay, but he can say, oh, wow, I'm actually having deja vu. I'm having a weird feeling right now. In contrast to that, to the EEG on the bottom, which is I took a picture of an EEG of a patient who had a tonic-clonic seizure. So right during the seizure, this patient is completely unconscious and he's having jerking and shaking similar to what you see in the movies. And what you can see is you don't have to be an EEG reader to know that like the whole brain is involved in the seizure, whereas on the top it's just one what we call focal area. You can go to the next slide. So I did a bunch of digging because I'm actually not a congenital CMV expert. And so I was trying to find large studies with large numbers of patients to kind of draw some conclusions. And I found some papers, but not large numbers of patients. So for example, here's one that I found that I think you can gather some information for. I didn't want to be too paper heavy, but this was a study from Japan where they got a total of 19 children when they went back through and they looked for all of the children who were born with congenital CMV from 1981 to 2007. So not very many. Did they miss some? I'm sure. But they just had access to one hospital where they could gather this 19 children. And so they were looking for trends. They were looking to see who had seizures, what types of seizures they had, what age at which they had seizures, and if they had seizures or not. So 37% of them, so less than half, developed epilepsy. So epilepsy I'll define on the next, on one of the next slides, which is the tendency to have seizures. This is typically when you think somebody has to take medicine for their seizures. So 37% of children had epilepsy, and this was more commonly seen when they knew that the children had congenital CMV when they were born. Typically, seizures occurred less than age of 2 at onset, or right around the age of 2. A few of them had had seizures at birth, but not all of them. So just a couple of them had neonatal seizures. 3 of the kids went on to have focal seizures, so just kind of staying in one area of their brain. And then 3 of them had this unique kind of epilepsy called epileptic spasms, which is a very brief seizure. It tends to occur in infancy. And then those children went on to develop other kinds of epilepsy, and classically epilepsy that I tend to treat, which is difficult to control epilepsy, commonly called Lennox-Gastaut syndrome. But again, it's basically just wanted to, I was looking for numbers and I was looking for data to show you. And so there were not a lot of children in this study. And I sort of wondered like how many were missed. That's what I was wondering as I was reading this. You can go on. So how are seizures diagnosed? Sometimes it's really obvious and sometimes it's tricky. Classically, the pediatrician is the first one who's alerted, or family medicine doctor is alerted to some sort of event. Maybe it's something that looks like a tonic-clonic major seizure. Maybe the person presented to the ER, but usually the gatekeeper is the pediatrician. And usually we're alerted, or the children are sent to a pediatric neurologist if it's something obvious like a large convulsive seizure, or if the pediatrician or parent is concerned that there are events that are stereotyped. Like my child did this weird thing the other day where they moved their head to the left and I saw some twitching of their face. And after about 30 seconds, they came to and they were like maybe a little sleepy and they were unresponsive. And then it happened the next day. And then I saw 2 days afterwards, something like that. When it's a stereotyped event with a beginning, a middle, and an end that kind of looks similar, that's when we get involved. And we have to, I always say, like, one of my biggest jobs is taking a complete history and sort of analyzing the events. Well, what was the child doing? Was it a hot day out and the child passed out because they weren't drinking enough fluids? Or was it just a normal day and these events are happening? Seizures are typically brief. I think this is an important thing to know, is that most seizures are like a minute, less than that, a minute and a half. If a child comes to see me and they have like 30-minute long events where they get up and they walk around and then they move their mouth and then they go back and sit down, that's usually not a seizure. Usually, not always, but usually seizures are brief with a beginning, middle, and end, and they're stereotyped. Common triggers for seizures, or people who have the tendency to have seizures, are illness, sleep deprivation, and in my world of epilepsy, children tend to have seizures more commonly when they're going to sleep or waking up from sleep, but that's not an always thing. But that's another commonality that we'll see. Next slide. What is epilepsy? So I actually rarely say seizure disorder. Most of the time I'm talking about epilepsy. If somebody has a head injury and has a one-time seizure, well, that's a seizure. But what we're talking about here is the tendency to have recurrent seizures. and then the child has epilepsy. And so the classic definition was always 2 unprovoked seizures, meaning just out of the blue. It wasn't when the child was sick or something like that. Sometimes it can still be when the child's sick. But anyway, so kind of a classically 2 unprovoked seizures. However, let's say your child has congenital CMV and they have a first-time seizure of life, they actually might already have epilepsy. I would have to be really thoughtful and know what their MRI looked like and know their exam and most likely do an EEG. But that by itself can get you the diagnosis of epilepsy as having 1 seizure, and using some math and some really educated decision making that came before me, based on what I know about this child, do they have a greater than 50% risk of having another seizure? Well, if they do, then that means that they have epilepsy. Next slide. And that's typically when we recommend an anti-seizure medicine. And an anti-seizure medicine doesn't change anything about that child's brain. It just makes it harder for that brain to have seizures. And it's important to know the difference between a seizure or seizure disorder and whether or not your child has epilepsy, because it's going to send you down a different path. And so that's why I try to be really thoughtful about using seizure disorder versus epilepsy. Most of the time we're talking about epilepsy, especially in the context of this talk. What's an EEG used for? An EEG is just a test. It doesn't, I can't actually predict tons of things from it. Sometimes it really changes the way I'm thinking, but not always. It's just a test, just like an MRI. And it can help tell us if a child is at risk for having seizures. And especially if you capture the event, you can determine if it actually is a seizure or not. But believe it or not, I take care of children who are on 3 anti-seizure medicines for seizures, for epilepsy, and their EEG can be normal in between seizures. And so sometimes you don't actually know the diagnosis or if the things are seizures or not until you capture it on an EEG. EEGs can tell us lots of other things. I just threw up an EEG on here. Again, I don't expect anybody to be an EEG reader, but see that big black line in the middle of the page? This is a generalized spike and wave discharge. And if you told me that this child had a convulsion and then this is what their EEG looks like, I would say, well, that child has epilepsy. They have the tendency to have seizures. This EEG kind of fits with them at risk for having seizures, and most likely I would say, let's start a medicine. You can see other things on an EEG. Sometimes I don't want to know about it, like focal slowing, diffuse slowing, and things like that. So if your child has an EEG, ask questions, ask to see pictures. Just because you're not a pediatric neurologist doesn't mean that somebody can't explain it to you, and kind of explain in the context what it means and what the limitations are. But nothing ever takes the place of a good history, good observations by the parents. Sometimes a video can be really helpful. Next slide. Despite the fact that I take care of children with treatment-resistant epilepsy, I'm here to tell you that typically seizures are controlled with the first medication used. Oftentimes it's not the first lowest dose, but sometimes it is. Just literally walked out of somebody's room who on the lowest dose of the medicine, they're not having any seizures anymore, and it just makes me so happy. Sometimes we have to increase the medicine a couple of times. That does not mean the medicine's a failure. And what I always say is, if I knew exactly how much to put your child on, I would put it on right now, but you don't want me to over-medicate your child. You want me to use the lowest dose needed to keep the seizures away. And most of the time, and many of the times, the first medication renders the child seizure-free. The chart that you see on the bottom right, there's definitely some arguments to be made about it, but it shows you in adults how likely somebody is to be seizure-free after their first medicine. Sometimes we have to go to a second medicine because we maxed out the first medicine and it didn't work, or sometimes somebody just has side effects to a medicine, because it's tricky to sometimes put children's brains on anti-seizure medicines and ask for no side effects initially. And so sometimes we have to move on to the second medicine. Sometimes we have to move on to a third, but when we're moving on to a third because the first 2 medicines didn't work despite being able to increase them high, then they have the definition of treatment-resistant epilepsy. And then we unleash another group of treatment options, which is beyond the scope of this talk, that we can go into about dietary medicines or even devices or even surgeries that we can do. But most people are seizure-free on medications. when they take them. All right, next slide. Why do we want to stop seizures? Like, let's say my child has really brief seizures. They don't convulse. Maybe they have a few a week. Why do we need to treat them? Why do we need them to stop? Well, actually, frequent seizures can actually cause damage to a developing brain. It can just kind of change the organization, and it can lead to abnormal pathways. And what I sometimes say is more seizures lead to more seizures. So not treating those seizures can cause people to have more seizures, which is a tricky concept to have. Next. And then frequent seizures can cause injuries and accidents. And I have to bring this up because it's a real life thing. I'm not saying this to scare you. If your child has epilepsy and you're on this webinar, I don't want this to scare you, but we do all sort of have this talk that we give about, okay, well, let's make sure that your child's always safe around water. Even when they're 7, they're not going to be left in the bathtub, even alone for 5 seconds, because injuries can happen. When your child's 15, they're not really, if they have epilepsy and have seizures, please don't leave them at home for long periods of time. And definitely when they're home alone, please don't allow them to take showers. Definitely not baths while alone, because accidents can happen, especially around water. And then the scary thing that we are obligated to talk about with all people who have the diagnosis of epilepsy are frequent convulsive seizures can lead to death. And it's something to know about, but know that it can be prevented. And at least we do our best to prevent it by doing our best to be aggressive with treatment of seizures when people have epilepsy. I always make this analogous to when you bring your first baby home and somebody talks to you about SIDS for the first time. It's like the worst thing that you're telling me right now. And I'm so scared of having this new baby that I take home. But we try to empower people with the tools that can be used to prevent SUDEP, just like we prevent SIDS by having babies sleep on their backs with themselves in a crib with nothing else. If for SUDEP, for some unexplained death in people with epilepsy, we say, well, having your child take your medications on time and every single day or twice a day if needed, that helps reduce SUDEP. Your child has convulsive seizures that are at night. Well, we need to do everything we can in our power to reduce the risk of them having seizures. And so that's why we treat. We treat to give this child the best life possible. And chances are we're able to get seizures under control. Next slide. After I just scared you with the SUDEP talk, I apologize for that. But most of the time, this is doable. This is manageable. Be your child's advocate, as Jasmine clearly is for her son. If you're take good notes. If you're noticing an event that you're concerned could be a seizure, write it down, talk to your pediatrician, make sure that you get the answers that you need to be okay with whatever they're telling you. And if that bothers you, if you feel like you're not getting the right answers, go to the next level and go to the next level. Pediatricians though, family medicine doctors, they are like so smart. I'm amazed. I could not go into that field. They just have to know so much about so much, and they are really good at figuring out what's a seizure, what's not, and when things are outside their realm and they need a specialist like myself. But take notes, stay organized, ask lots of questions, and that's my last slide. If your child does have epilepsy, report all the seizures, report any concern for side effects. I cannot say that one enough. I think sometimes when we start somebody on a medicine or on a second medicine and somebody has side effects, they'll just brush it under the rug or stop the med, or what's even worse is stop the medicine and don't tell me because, I don't know, you always tell me, right? So always tell us if your child's having side effects, because we have tricks that we can use. We can go back down. But our sort of mantra in pediatric epilepsy is no seizures, no side effects. And that's actually really, really true. Also, know your rescue plan. If your child has epilepsy, know your rescue plan. Know what medications to use when, have them with you. It's just like, the way that you can empower yourself. We also recommend that any child who's had a convulsion, that their caregivers be CPR trained. Chances are you will never need that. It's just another empowerment tool. Just like your rescue meds, I hope you never use them, but have them with you because you never know. Epilepsy is quite unpredictable and seizures are unpredictable. And so you might never know when you need it. Okay, that was my last slide.
So thank you so much for that presentation. It was definitely in depth and gave us a lot of information for not just those who advocate for families, but also families themselves and providers. So thank you so much for that ability to kind of go across all of those different populations to give us something to be armed with. The Epilepsy Foundation also would like to just remind everyone on this call that we do have a 24/7 helpline as well. And our particular helpline allows people to be able to take some information about what your needs may be and then be able to connect you either locally or even nationally with some of those resources. So if any of the topics that were mentioned today during the presentation or that you see on the screen are things that you would like to have more information about, be able to find some more resources or a provider that can help you to answer some of those questions, and you are yet connected to them, please do not hesitate to reach out to our 24/7 helpline. It is in English and in Spanish. And then, of course, again, Dr. Fleming is continuing to provide resources in the chat for those who may want more information around CMV and some of the resources that the CMV Foundation can provide as well. So we want to make sure that we say thank you so much to all of our different providers, speakers, and panelists. This has been incredibly informative. We want to make sure we let everyone know that we also have a survey that is going to appear on the screen now. If you can please use the QR code to give us some feedback. We will also put the link in the chat for you guys so that you guys can take that. That would be great. We want to provide more of these webinars, but we want to know exactly how we can do that in the best way that will serve as many populations as possible. So that feedback is important, not just for the aspect of what you heard today, but what you would also like to hear in the future. We also did get one question, so I'm going to put that in the chat so that our speakers can see that, so that you guys can answer that question either to either one of our speakers who may be able to provide that information. That would be great. And we received another one too. So I'll let you guys answer that first one, and then I will get the second one for you.
So great question. So the first question is, if a child has a gray matter malformation or neuronal migration disorder and epilepsy, would they automatically be tested for CMV? I think it's fair to say the answer on this one is no. Oftentimes this is not found initially right after birth and probably well within the window in which we could test for it. If a migrational disorder is found early on, inside the period before they leave the hospital, for example, after they're born, then yes, the testing would occur. But oftentimes this isn't found for months to sometimes even years later. Which ties a little bit into the second question, which is, can someone with congenital CMV develop seizures in their mid-teens? What a good question. Let's say that the child had a brain malformation because of the congenital CMV. Most likely they would develop seizures when they were younger, but absolutely, I have children who I'm sure they have malformations their whole life. Sometimes they A, never have seizures, or B, can develop seizures later. But it's more common that they have seizures when they're younger. Great questions.
Thank you so much. I don't see any more questions. So and make sure that we give people time. I've also gotten a note that the QR code has been deactivated. So we do apologize for that. We did put the evaluation link in the chat for you guys, and we will do that again now. This will also be emailed out to everyone. So as we go to the next slide, we'll take that down because again, we apologize for that. We want to again say thank you so much to everyone for watching today. Again, please do remember that June is CMV Awareness Month, so to take this time to look at some of those resources, share those with some people. Definitely, if you are a parent of a young child, I have a 2-year-old, so I continue to share this information with my child's daycare providers and nannies. So please, even if you are not personally affected by CMV, please do still consider some of these resources that you can share to others so that we all can know more. But we want to say thank you to everyone. This has been a great opportunity for us to be able to make sure that we are lifting up this particular population like Jasmine and some of the other mothers and parents that are on the call and joined us today. And we want to say thank you, and we stand with all of you, and you guys enjoy the rest of your day. Bye, everyone.